I want to thank Rena for the invitation for this lecture. It's always an honor when you do a lecture. Well, some of the things I'm going to talk you about, it's already well described by Rena. Rena told you about our butterfly. This butterfly lies just above the manubrium of the sternum. And this is easy for us because when we look at it in the ultrasound, you just go right here, a little further up, and you found the thyroid. The thyroid gland has a very, very significant role because it regulates metabolic functions, including cardiac rate and output, lipid catabolism, skeletal growth, oxygen, and heat production. Very important, everyone. The anatomy is already described by Rena very well. It doesn't need to stress on this. I'm just pausing on the lymphatic drainage because for us, for the radiologists, it's very important in staging thyroid cancer. And that's why we have to emphasize that it's multi-directional. No lymph node in the neck is accepted when we look for possible metastasis. Every lymph node is included and is possible infiltrated. These are the groups, the lymph node groups. This is the region, the group 6 that is the most common affected by thyroid pathology, and the 5th group. These are the 2 groups that most commonly are affected by any thyroid pathology. I'm not going to stand and talk more about diffuse thyroid disease. You will hear from other lecturers. I'm just going to give a few remarks on riddle thyroiditis because it's the only one that can spread beyond thyroid's capsule. You can see a massive pathology that goes around and infiltrates surrounding tissues. And you have to be very careful to look at the clinical history of the patient, not to confuse it with any other pathology like lymphoma. When we say about a nodule, we say about a lump that is a focal disease and can be due to multinodular goiter, to adenoma, to a colloid cyst, to a colloid nodule, and to tumors, a papillary carcinoma, a follicular, anaplastic, a medullary cell carcinoma, lymphoma, or metastasis, or just to thyroiditis. If we have a nodule, we have to see if it's palpable or impalpable, if it's solitary or multiple, its size and shape, the cogenicity, if it has any cystic change, the definition, the halo, all these are very important. If it has any calcification and its vascularity. If we do a thyroid mass breakdown, we'll see that the majority of the lesions are benign. And 85% are hyperplastic colloid or nodular hyperplasia. Another 5% is due to adenomas. And carcinoma accounts for about less than 10% of the lesions of thyroid, with the papillary and follicular more than 80 to 90% of the carcinomas of the thyroid. This is very good for us because are the least aggressive of the carcinomas of thyroid. The most aggressive is the anaplastic, which accounts only for 1 to 2% of all carcinomas, which means only 1% of thyroid lesions. Who to scan? You have a patient, it has a focal lesion. Or maybe it doesn't have anything palpable. You have to scan someone with clinical goiter. with palpable nodule, someone with cervical lymphadenopathy of unknown etiology, a thyroid lesion as an incidental finding on CT or MRI, and thyroid lesions on PET scan. You don't do scanning and procedures that have a cost for every hyper or hypothyroid patient without palpable pathology as a general rule. Clinically, if you have a lump, the features for thyroid cancer are history of head and neck radiotherapy, history of MEN2 syndrome, an age less than 14 years or more than 50, a male gender, a growing nodule, firm or hard nodule, accompanying cervical lymphadenopathy, and persistent dyspnoea or dysphagia. Radiological features, a large size. That's not necessarily. We've seen cancers with very small size. Presence of microcalcifications. This is as well not always malignant. The hypervascularity is a very important feature. The hypogenicity on ultrasound and lymphadenopathy. Every one of them can be benign or malignant, but if we see one of them, we have to be alarmed for malignancy. The main risk factors are the young age, the male gender, the solidarity, cold on thyroid scan nodule, past history of radiotherapy. We have to remember that elderly women with multiple benign nodules are very common. We don't send everyone for biopsy. Thyroid cancer staging. You will listen to every one of the chapters of this thyroid pathology again and again till at the end of the seminar, but this is very important for the radiologists because our task is to do the staging. Successful treatment of thyroid malignancies highly depends on accurate preoperative staging. Usually, a combined ultrasound and post-contrast CT scan of the neck is the preferred protocol for thyroid cancer staging, and we use the TNM system to describe the stage of the disease. For anaplastic thyroid cancer, we said it is the most aggressive cancer of the thyroid. There is no accepted staging system, and all patients are considered to have stage 4 disease. T is for tumor. We describe the size of the lesion in the thyroid, possible extension to the surrounding tissues, and possible advanced disease, not only in the area of the neck, but distant metastasis as well. If we are talking about anaplastic carcinoma, we usually put the prefix C because, as we said, every patient is considered to have stage 4 disease. And for node, we have to describe every nodule or the group of nodules because, as we said, at first the cancer spreads to the group 6, surrounding around the thyroid area, but later it spreads to the other neck groups as well as the mediastinum or elsewhere. And for metastasis, thank God we don't have many patients at the first diagnosis with distant metastasis. It's not that common, but some unfortunate, they do have distant metastasis. The techniques for thyroid imaging, we have a number of techniques. I'm just going to talk about computer tomography and magnetic resonance, the MRI of the thyroid, because all the others will be covered by other lecturers. In general, thyroid scan is used for functional tests that assess the activity of the thyroid. Ultrasound provides information on gross morphology, and biopsy provides histological information. CT and MRI have an adjuvant role in the thyroid disease assessment. They are less sensitive than ultrasound detecting and characterizing intrathyroid lesions as possible malignant or benign. They are particularly used for staging thyroid cancers and as they are useful in evaluating regional lymphadenopathy. They also assess regional extension of the tumor, involvement of the trachea or esophagus, or spread to the mediastinum or retrotracheal region. And they can detect distal metastases. They are also recommended to evaluate the occult metastases, mediastinal or retropharyngeal, in post-thyroidectomy follow-up cases with elevated thyroglobulin level and negative sonographic findings. CT sensitive and detective intraglandular calcification, something that MRI cannot do. And MRI with diffusion-weighted images and MR spectroscopy can help in differentiation between benign or malignant nodule. Fusion, PET-CT, and MRI have a promising role. We will hear about it from other lecturers. So, about the CT of the thyroid. Post-contrast CT, it's no use to do without contrast. It doesn't have any more to give us. Post-contrast CT is the preferred imaging modality for thyroid cancer imaging. Multiplane images help to identify spread of the disease locally and distally. It's cost-effective and fast modality compared to MRI. As you can, this is a benign multinodular goiter. It just spreads behind the trachea, displacing esophagus, but it's benign. This is a benign nodule. You can't say if it's a benign or malignant with CT. It's just a nodule. You can say if it's cystic by measuring the Council unit density, but you can't say anything more. This one is malignant. It has calcifications. We already done a biopsy. The CT was for staging. This one is a follicular cell carcinoma. As I said before, it was already biopsied with a metastasis. As you can see, the metastasis has the similar features with the tumor in the gland. This is a stage 4 disease, local spread. You can't say if there is any anatomy left, just displacing the vessels, nothing more. And this one is an aplastic carcinoma. You can see how huge it can be. In very short time, it doesn't mean that the patient waited for long and came to us with his huge mass. The lesion is on the left lobe. The lymphadenopathy is on the right lobe. It's considered to have N2 staging for lymph node infiltration, though in the area we don't see any nodes. Thyroid carcinoma and metastasis to the lymph nodes. As you can see, the metastases have calcifications, as the primary cancer has. It's the similar disease, the similar pathology. Liver metastasis, this is the same patients on the other image I showed you. And small lung metastasis. And here you can see the bone metastasis, blastic, osteoblastic, and osteolytic metastasis. Thyroid is very aggressive when it reaches this stage, and it has a very high vascularity even in metastasis. The MRI. Using the T1 weighted images or T2 weighted images, we can assess the location and the size of the thyroid lesions. These sequences have no specificity for distinguishing benign from malignant nodules or assessing the functional status of these nodules. They can give information about central or cervical lymphadenopathy. MRI has high sensitivity but very low specificity and negative predictive value for lymphadenopathy. We can't say if a lymph node is infiltrated or not, because if it's small, we can't really assess if there is any disease in it. As a general rule, ultrasound is used for assessing central lymph nodes around the thyroid, and CT and MRI for cervical lymph nodal assessment. Characteristics done on ultrasound suggest malignancy in a lymph node, such as large size, round shape, rich blood flow, high hypoechogenicity, cystic degeneration, irregular shape, loss of architecture, hilar architecture, and microcalcifications cannot be recognized on CT or MRI due to their lower resolution. This one has thyroid cancer that extends beyond thyroid capsule and surrounds carotid artery. As you can see, you cannot distinguish the borders of the infiltrated lymph nodes with the thyroid pathology. Sometimes after chemotherapy or radiotherapy, when these lesions shrink, we can separate each anatomical lesion. And this one is with contrast, with gadolinium, T1, and as you can see, there is a huge mass surrounding the carotid. You cannot distinguish if it's lymphatic tissue or just the thyroid pathology. The diffusion-weighted images. Diffusion-weighted images is based on the random translation motion of the water protons in the intra and extracellular spaces and also in intravascular spaces. We measure it using the ADC values, apparent diffusion coefficient, in area through time. Growing tumors have increased cell attenuation, consequently increased amount of diffusion barriers, and as a result, the motion of the diffusion capacity is restricted and ADC values decreased. These give us bright areas in the areas of pathology. One significant limitation of this method is that the nodule we want to study must have a minimum size of 8 millimeters. The MR spectroscopy is about chemistry. Provides information about the chemical environment of the nuclear spin, such as number of chemical bonds, neighboring nuclei, and overall chemical structure. MR spectroscopy can help the differential diagnosis between thyroid CA and benign follicular lesion. Raised choline levels, choline peak is identified in almost all carcinomas, not only in the thyroid, in brain, or any other carcinoma. We have some numbers that we can compare and see the aggressiveness of the tumor. And it's well established that normal thyroid tissue and benign lesions show no choline peak. There is as well size limitation, at least 1 centimeter of the lesion, for accurate measures of the nodule chemical structure. And this is a diagram we usually take. You can see the choline peak and the NNA. These are some chemicals that have to do with the anatomy of the cell. Now, before I proceed to this slide, I have to tell you that it's a usual, we are usually asked, why don't you do MR spectroscopy or MR diffusion-weighted images to every patient? Because of time and money. We have a patient that has a nodule, he has to know if he has cancer, and the histology of the cancer. You don't do every image you have, every imaging method you have, because it costs and because you have to have a result about the histology to proceed with the therapy. You don't just do every imaging method you have in hand. Now, how we manage an incidental finding of thyroid nodule or CT or MRI? We have a number of patients. We do CT or MRI for other reasons. And we know that 8% of adult population have palpable nodules. A greater percentage have impalpable nodules. And there is high variability in radiologists' reporting practices for incidental thyroid nodules detected or CT and MRI. 15 to 18 of studies that include the thyroid. It's a quite big amount of studies. Most common response, they recommend ultrasound. There is a disagreement for patients with small nodules, smaller than 1 centimeter, and patients with multiple nodules and history of cancer. It is generally accepted that there is low prevalence for malignancy in incidental thyroid nodules. But there is a need for practice guidelines. We still don't have practice guidelines about what to do about the incidental nodules we find. No public recommendation for nodules on CT or MRI. Small thyroid cancers have an excellent prognosis. We have to tell the patient this. If he or she has to do further investigation, we have to stress this out, but don't worry. Even if you have something, it has an excellent prognosis. We're talking about costly procedures. We have to avoid over-investigation. You have to do with a huge amount of studies. You must spread panic every time you see a nodule. More comprehensive evaluation of neck nodes is necessary as possible accompanying pathology. We have to assess every patient differently according to his clinical history. Just a few words about parathyroid. CT and MR imaging have an additional role as well in parathyroid gland imaging. The main reference for CT or MRI is for detection of possible adenomas. A correlation of CT and MR images with ultrasound and or radionuclide scan is almost always a necessity. Due to their small size, when the adenomas have a small size and oval shape, small adenomas are easily mistaken for lymph nodes when they are not at the expected location. This one was one of the exceptions. We're talking about a carcinoma of the parathyroid gland. And this one is adenoma of the right lower parathyroid gland. And this one is another one. You can see it as a bright signal lesion using a technique that we suppress the fat. And you can easily recognize when it has this size. When it has a lower size, you can see that this is a lymph node. You could see that they have very similar features. So, ultrasound and or FNA remains the mainstay of thyroid imaging. Nuclear medicine has a limited role, but you will listen about it in other lectures. CT, MRI, and PET-CT or MRI have a small number of specific indications. We may say a small number and it sounds like it's not important, but it's really important. We're talking about numbers, not severity, okay? Ultrasound is the method of choice for thyroid suspected pathology. CT and MRI are used mainly as a complementary in search for nodal involvement, local extension of the disease, or metastasis. Thank you.